in 52 countries where Hmpxv is not usually reported. In the United States, there have been 605 cases in 34 states, plus the District of Columbia and Puerto Rico. In the United States, there have been no pediatric cases and no deaths. In Oregon, as of this morning, there are 1 confirmed and 5 presumptive cases. 3 of those presumptive cases were identified yesterday. The counties of those cases are Multnomah, Lane, and Washington. Just a distinction, confirmed cases have tested positive for Hmpxv at the CDC, while presumptive cases have tested positive for orthopox viruses, which is the broad family of viruses to which Hmpxv belongs at the Oregon State Public Health Laboratory. Thus far, Oregon providers have sent 35 specimens from 20 patients for testing at the Oregon State Public Health Laboratory. Specimens from 2 patients are currently pending. Typically, Hmpxv has an incubation period of 6 to 13 days, but can be as long as 21 days. Illness starts with fever, headache, swollen lymph nodes, muscle aches, and exhaustion. The rash may appear at the same time or 5 days later, and generally involves the face, palms and soles, and mouth, and less often the genitals and eyes. The rash can be painful or itchy and moves through predictable stages, including what look like pimples, blisters, and scabs. Illness lasts 2 to 4 weeks. And based on data on the variant currently circulating in non-endemic countries, the case fatality rate is 1 to 3%. But in contrast, in the current global outbreak, the presentation is a bit atypical. The initial flu-like illness can occur, but is sometimes very mild or not present. The location, appearance, and duration of rash are also atypical in that rash is presenting more diffusely and more often on the genitals and around the anus. Sores may also be present inside the mouth, vagina, or anus. The rash can be subtle and may move through typical stages more quickly. This illness presentation has a few implications for the diagnosis of Hmpxv. First, people may not readily seek care for evaluation and testing. Second, when they do seek care, most people will likely present to outpatient clinics rather than hospital settings. Third, clinicians may not recognize this more subtle presentation as Hmpxv. And finally, the rash of Hmpxv may be confused with rashes associated with syphilis, herpes simplex virus, and varicella zoster virus. That said, public health agencies have reported co-infections with chlamydia, syphilis, herpes simplex virus, and varicella zoster virus. Hmpxv is transmitted during direct, close, personal, skin-to-skin contact with a person who has symptoms. In addition, contact with towels, clothing, bedding, or other objects used by a person with Hmpxv may also transmit the virus. Less commonly, Hmpxv may also be transmitted through large respiratory droplets or oral fluids via prolonged face-to-face contact. These types of contact may occur during activities such as sex, cuddling, massage, kissing, talking closely, and or caring for someone with Hmpxv. Hmpxv spreads from the time symptoms start to when sores, including scabs, have healed with a fresh layer of skin. The genetic material of Hmpxv has been found in semen from patients with Hmpxv, but is not yet clear whether functional virus is present in semen, vaginal fluids, or blood that can cause infection. Globally, nationally, and in Oregon, Hmpxv was initially associated with travel to non-endemic countries with reported cases. However, more recent cases do not have a history of travel, indicating community transmission within the US and within Oregon. Without intervention, a person with Hmpxv will transmit Hmpxv to, on average, about 2 other people. In comparison, this same number for the Omicron variant of COVID-19 is 8. Therefore, in relative terms, Hmpxv is not very transmissible and will not spread like COVID-19. At the same time, its control requires a coordinated, thoughtful public health response. While anyone can be affected by Hmpxv, the current global outbreak happens to largely affect gay, bisexual, and other men who have sex with men. I point this out not to say that men who have sex with men are the only people at risk for Hmpxv, but that right now our priority should be empowering men who have sex with men, the larger LGBTQIA+ and queer communities, and their healthcare providers with information, testing, prevention, and treatment strategies. We'll go through each of those. So first, information. OHA has released guidance to providers on case definitions, recognizing Hmpxv, and testing procedures. I, in partnership with members of the Multnomah County Public Health Communicable Disease Team and local providers, all of whom identify as queer, issued a community letter in advance of Pride events here in Oregon. The OHA Community Engagement Team has begun to work with community-based organizations to develop culturally tailored awareness and prevention messaging. And the OHA Communications Team will offer regular updates of facts and data through all platforms. In addition, a press release will accompany this press conference. In the next week, we will also establish a provider advisory group for our response. Second, testing. Initially, OHA implemented an approval process for testing, which is quite common. This process, however, has become a barrier to testing, and we will now allow providers to send testing directly to the Oregon State Public Health Laboratory based on their clinical suspicion without prior approval. OHA, however, will remain available for consultation at any time. In addition, LabCorp announced that it will offer Hmpxv testing with a turnaround time of 1 to 3 days. Therefore, clinicians can decide to send specimens directly to LabCorp instead of the Oregon State Public Health Laboratory. We expect that other private labs will offer testing in the next coming weeks. Third, prevention. Broadly, vaccine-based prevention comes in 2 flavors: post-exposure prophylaxis and pre-exposure prophylaxis. We currently have 193 doses of vaccine in Oregon, with further federal allocation pending. Post-exposure vaccination can be given within 14 days of exposure to prevent Hmpxv infection. The sooner the better, however. With the limited supply of vaccine from the national stockpile, we focused on vaccinating contacts of people with confirmed or presumptive Hmpxv. Through local public health partners, we've also provided vaccination within 14 days of attendance at events or travel to locations where Hmpxv transmission is likely or has been documented. To date, we've distributed 26 doses of vaccine to LPHA partners, and at least 8 doses have been administered. Pre-exposure prophylaxis, on the other hand, is given before an exposure to prevent Hmpxv. When more vaccine becomes available, our goal is to offer vaccination to people at increased risk of exposure to Hmpxv, which broadly includes cisgender and transgender men who have sex with men, and transgender women who have sex with men who've had more than one sexual partner in the prior 2 weeks. This prioritization is consistent with that used by jurisdictions already offering pre-exposure vaccination. Finally, antiviral treatment is available for people with or at risk for severe disease. Severe disease is defined as hemorrhagic disease, severe rash coalescing over large areas of skin, infection of the central nervous system, eye infections, sepsis, or hospitalization. People at risk for severe disease include children under 8 years of age, pregnant people, people with compromised immune systems, and people with atopic dermatitis or blistering skin diseases. The antiviral is called tecovirimat, or TPOXX. It interferes with viral assembly, is safe, and is given for 14 days in oral or IV forms. As of today, we have 25 courses of TPOXX in Oregon, 10 have been distributed to LPHAs, and 3 have been dispensed to patients. In terms of guidance, for providers, we recommend being on the lookout for Hmpxv, knowing that the presentation is subtle and may involve the genitals and perianal area. Have a low threshold for testing. We recommend comprehensive sexual health screening at the time of Hmpxv testing, including HIV, syphilis, gonorrhea, and chlamydia. If providers aren't sure if they should send Hmpxv testing, we're here for consultation, the Epi on Call here at OHA, and we'd be happy to talk through cases and guide folks through the testing process. Also, we recommend talking to colleagues, educating each other, and spreading the word about Hmpxv. Local public health authorities are also key resources for providers and their colleagues. For community, especially for members of the LGBTQI+ community, the queer community, need to take a deep breath. Like COVID did, Hmpxv may call up the deep trauma of having lived through 2 pandemics, only to face a potential third. We know that pandemics thrive in silence. Talk to trusted people in your life, your friends, and your sex partners. Check in with your body. How are you feeling? Look at your skin. Use a hand mirror or your phone to look at your genitals around your anus. If you don't feel right, have a rash or other concerning symptom, avoid close, personal, and skin-to-skin contact with others, and talk to your provider. We suggest that folks seeking care remind their providers that Hmpxv is here in Oregon. And if you don't have a provider, your local public health agency can be resources to find one. Furthermore, local public health clinics, including sexual health and STI clinics, are great resources for information and testing, and if necessary, vaccination and treatment. For further guidance when thinking about attending a festival, concert, party, or other event, consider the amount of close, personal, and skin-to-skin contact that may occur. We can think about risk on the spectrum. For example, events like sporting events, concerts, where people are more likely to be fully clothed and unlikely to have skin-to-skin contact, are safer when compared to clubs and parties where people are wearing minimal clothing and there's often skin-to-skin contact, or spaces like saunas, bathhouses, or sex clubs where there's minimal to no clothing and often sexual contact. When thinking about sex, check in with your partners. Tell them how you're feeling, whether you've had any recent illness or rashes, especially on the genitals or around the anus. And invite them to do the same. If you or your partner have been sick recently or are currently sick or have any new rashes, avoid close, personal, and skin-to-skin contact and talk to a healthcare provider. Open communication with partners and avoiding sex while you're sick are just good practices in general. If you choose to have sex, choose activities that don't involve direct skin-to-skin contact or kissing. Cover rashes, wash hands, towels, bedding, toys, and other gear, and consider limiting your number of partners. If you're concerned that you may have been exposed to Hmpxv, reach out to your local public health agency to talk through the exposure and to discuss whether post-exposure vaccination is the right next step. Thanks for listening. Those are my remarks, and I'm happy to take any questions.
Great, thank you, Dr. Menza. And as I mentioned earlier in the chat, for our media partners, please use the raise your hand function, and then I'll add you to the queue and call on you for the questions that you might have. We've also got, as Dr. Menza mentioned, health officers on the Zoom here as well to also help answer questions from multiple counties. So we are here to answer your questions. So please raise your hand and I'll call on you. Thank you. Okay, thank you so much. Our first question comes from KVAL TV. Go ahead.
Hey, thanks for taking our questions today. Could you just talk a little bit more about the treatment and prevention for this, kind of talk about the vaccines again?
Sure. Are there particular questions or just in general? Or specific? Yeah. I'm happy to review what I talked about, or if there are particular questions or clarifying things that you'd want to know, I'm happy to add additional information to. Just let me know.
Sorry, I think I was muted. Yeah, just in general, please.
Okay. Yeah. So in terms of prevention, so the vaccine-based prevention comes in 2 forms at this point in time. We have the post-exposure prophylaxis, so after a potential exposure, and the pre-exposure prophylaxis. So that's, that's like, vaccinating against MMR prior to while we're children. But in this case is you're anticipating exposure and then vaccinating folks who are at high risk for exposure. So post-exposure vaccination can be given within 14 days of an exposure to prevent Hmpxv infection. And we do say that the sooner the better. And what folks have been doing, and most jurisdictions are doing at this point in time with the limited supply of vaccine from the federal government, is we've really been focusing on vaccinating contacts of people with confirmed or presumptive Hmpxv. But as we have more vaccine available, there's also the opportunity to vaccinate folks who may have attended events or traveled to places where transmission is likely or has already been documented. And that's another way to think about post-exposure vaccination. The additional ways we can think about distributing post-exposure prophylaxis or vaccination in sort of creative ways, and these are sort of potential looking at the future when we have more vaccine, is that there may be some cases who are not interested in naming or identifying contacts, but may refer or ask folks to come in, or would give people a card to come in to their local public health agency to get vaccinated. So we may think about sort of a referral system, which may be seemingly more confidential, feels a bit safer, feels like it protects privacy a little bit more. The other option too is to provide vaccination in and around kind of events or venues where there may be a higher risk of Hmpxv transmission. So again, that's the post-exposure world of prophylaxis. And then the pre-exposure vaccination is really trying to be broader. And so while what we're trying to do there is offer vaccination prior to exposure to people at an increased risk of exposure. And thus far, I'm going to do the quick tally in my head. I believe about 4 or 5 cities, jurisdictions, have received enough vaccination, or in the thousands of doses, to be able to provide pre-exposure vaccination. And in those cases, they've been focused on providing vaccination largely to cisgender and transgender men who have sex with men, and transgender women who have sex with men who've had more than one sexual partner in the prior 2 weeks. And so we would think about doing the same thing here when we had more vaccine to make that happen. So then, and just, kind of a few details here. We are sort of awaiting further information around our allocation. Currently, we have 193 doses in Oregon. We're currently awaiting to hear word. I believe it may happen this week or next week. I just saw an email of the number of doses we may see in Oregon in the next few weeks. So that vaccine planning and rollout at the federal level is still happening, and we'll be getting more and more information there in the next few days, in the next few weeks. Then, so that's the situation there. And then you'd also ask about treatment, and I will mention that before we move on to treatment, vaccination also comes in 2 flavors in terms of the type of vaccination. The one that we're using is called Jynneos, and it's a vaccine that is given at day 0 and then 28 days later. There is another vaccination called ACAM2000. It's been used previously. If you know folks with scars on their shoulders, that's usually from ACAM2000 because it requires a scarification procedure. At this point in time, we are not using ACAM2000, partly because the side effects can be quite severe. But should we need it, it is also there in reserve. Okay, moving on to antiviral treatment. So again, antiviral treatment is available for people with or at risk for severe disease. And the antiviral treatment is called tecovirimat. or TPOXX, TPOXX. It interferes with a protein that allows the virus to assemble. And overall, very safe, few side effects, and is given for 14 days. And there are other antivirals that may also potentially be effective or have activity for Hmpxv, but right now tecovirimat is the drug of choice. I hope that answered your questions. Thank you.
Thank you for that question. Our next question comes from Lillian with OPP. Go ahead, Lillian.
Hi, thank you for taking my question. I had two kind of different questions. With the different presentation that you're seeing in these latest cases, would that be considered a sexually transmitted disease, or is it still not because it can be transmitted other ways? Like, how do you define that, and what's the most accurate way to? Sorry, what's the most accurate way to report it? I just want to make sure we're doing it right.
Totally. So it's a fine sort of line. So the way that I think about that, the way I conceptualize something that's sexually transmitted versus what I would say is sexually transmissible, is that sexual disease or an infection that's sexually transmitted requires oral, anal, or vaginal sex for transmission, whereas monkeypox or Hmpxv doesn't necessarily require those things, those particular activities, but is transmitted during sex because it involves direct, close skin-to-skin contact and personal contact with oral and potentially respiratory droplets. So that's kind of the distinction.
Super helpful in terms of clarification. I appreciate that.
Got it.
So it's transmissible through sex because of the close skin-to-skin contact, but it does not require a sexual act or contact to transmit.
That's right. Okay.
And then my other kind of completely different question is, you said that there were no pediatric cases yet, but that it is of a particular danger to children under age 8. So can you tell us more about how it would present in children, what to look for, and if there's any concern right now of that becoming a thing?
Yeah, so that's a great question. So right, we don't have any pediatric cases in the United States at this point in time. In Europe, there are 3 cases, 2 that are confirmed and 1 that is pending confirmation. We don't have information about how those cases came to be or their current presentation. What we do know that is that in studies of Hmpxv in other countries, endemic countries, where transmission has been occurring for longer periods of time, pediatric cases are more common, and usually through household transmission. And the worry is that we would see more likely a more severe rash. And again, we're not sure with this sort of atypical presentation that we're seeing in adults, whether that would translate for pediatric cases, or we would see a more typical, more severe rash, potentially. With the other thing that can happen for pediatric cases is if there are sores in the mouth, dehydration, it can also cause sort of a gastroenteritis or a pneumonia. So those are the types of things that we would be worried about in children. And oftentimes we're more likely, because children are at risk for severe disease, to offer antiviral treatment right up front when a child would be diagnosed or a very, very high suspicion of Hmpxv in that child. Yeah. But as we know more information from other countries as they report out on cases, we'll be able to sort of update what that presentation might look like and what pediatricians should be looking out for as well. Yeah.
Thank you for those questions, Lillian. Those were great questions. It looks like we need a reminder to tell folks that if you have a question, to please use the raise your hand function, because we also have Dr. Bauman with Washington County, Dr. Everson with Multnomah County joining by phone, and Dr. Guzman of Lane County. So we've got some wonderful medical professionals here helping us today inform the public. Again, so we've got one more hand raised here. This is from Fedor Zarkin with the Oregonian. Go ahead, Fedor.
Hi, Tim. Thanks for taking my question. So far from what we've heard from you and other health officials is essentially that the current outbreak can affect anybody, but primarily is affecting men who have sex with men. So what would you say to people who are seeking more clarity and who might say, hey, I'm not a man who has sex with men. This doesn't affect me. What would you tell those folks?
Yeah, I would, in general, I would just sort of look at or reassess or assess one's kind of behavior. And again, talk to people in their social circle, whether folks know about it, whether folks know people who've been experiencing Hmpxv. And so I would, yeah, so I agree, yes, this outbreak has largely been affecting men who have sex with men. But there is always the potential for transmission to occur, through other means than sex and sexual transmission. In addition, there are other forms of skin-to-skin contact that could transmit Hmpxv. In addition, there's nothing sort of special or particular or about contact between men that inherently increases the risk of Hmpxv transmission. So, but largely in terms of sort of assessing one's risk is sort of talking to one's social and sexual networks and the folks in those networks to kind of assess what's been going on. Again, sort of just like, I provided guidance around, again, pandemics thrive in silence. So just talking more and more with close people in their lives, and again, folks in their social and sexual networks about Hmpxv and about potential exposures and knowledge of what's going on in their circles.
So just to follow up, so does that mean that, let's say if someone, as far as they know, no one in their social network is a man who has sex with men, what would you say to those folks? Does that mean that they no longer need to think about this? Or what's the risk there and what should they do with that?
Yeah, I mean, I think if they're not having close personal contact with other people who might have Hmpxv, then the risk is quite low. And again, it's sort of prolonged either face-to-face contact or direct skin-to-skin contact. So kind of taking stock of what behaviors folks are engaging in is more probably the bigger issue than sort of whether they know someone who is a man who has sex with men.
So ultimately, for men who do not have sex with men and do not engage in close contact with men who have sex with men, then for the risk is low? I'm not sure I'm understanding quite the categories.
Okay, so we think the people who have increased risk of exposure are men who have sex with men, including cisgender and transgender men who have sex with men, as well as transgender women who have sex with men who have had more than one partner in the last 2 weeks. Those are the folks that we think are at highest risk for exposure to monkeypox or Hmpxv.
Okay, thank you.
Thank you for those questions, Fedor. I do see you, Kval. I see you have a follow-up, but I'm going to call on Jenny Young with COIN because it's the first time we've heard from her. So Jenny, you are up next. Go ahead.
Hey, thanks so much. Apologies if you covered this on the outset, but my questions are about vaccines. So yesterday, officials in San Francisco and New York announced that they don't have enough. San Francisco has a waiting list of like 400 people. So can you just address that for Oregonians? What are the biggest things you want people to know about the vaccines? You said we have 193 doses here. Is that troublesome? Is that worrisome? What are your conversations with the federal government about getting more? And are people calling and do you know about any waiting lists around the state, et cetera, and just anything else you think people really need to know about vaccines?
Yeah, great question. So, right. I think New York City received 6,000 doses, and I believe they're already all spoken for. And that happened within within days. And so, yeah, the demand, and these are jurisdictions that are already providing vaccination for pre-exposure. So not just vaccinating folks who've had contact or exposure. They're doing both of those things at this point in time. And so, right, the demand and the need for vaccine currently outweighs and outstrips the supply. And so at this point in time, we're working with federal partners as much as we can. We're advocating as much as we can on behalf of Oregonians to get more vaccine. At this point, we don't necessarily have waiting lists in the same way, partly because we feel we don't have enough vaccination to start with those pre-exposure vaccination strategies. So at this point in time, we're reserving vaccine, or we're giving vaccine out to folks who've had contact with a presumptive or confirmed case of Hmpxv, or people who have been at events or have traveled to places where Hmpxv is likely, or where transmission has been documented. So at that point, this point in time, we're really focusing our vaccine efforts on that post-exposure vaccination, with hopes to expand that as more vaccine becomes available. I do believe we'll hear more information. I believe it's actually tomorrow. I have just read an email while reviewing this that we might hear about numbers of vaccine doses coming our way potentially tomorrow, and if not, then hopefully next week.
Thank you for the question. We have a follow-up question from Kayvel. Go ahead.
Hi, thanks again. So this question is actually for Dr. Guzman, about do we know how many cases are in Lane County and how many vaccines are available in Lane County?
Hello. In terms of number of vaccines that we have currently, the number is very low. We have about 8 vaccines, and but we hope that we will be able to get more. And what was your other question? I'm sorry. Are you muted?
Okay, there we go. Now it's unmuted. Sorry about that. My other question is, how many confirmed and presumptive cases do we know of in Lane County?
Sure. So we have 3 confirmed presumptive cases, and these 3 need to be confirmed by the CDC. So we have 3 confirmed orthopox virus cases, and these 3 still need to be confirmed by the CDC. And about 8 suspects.
Thank you for that question. And thank you, Dr. Guzman, for your answer. We have a follow-up question from Lillian with OPB again. Go ahead, Lillian.
I just wanted to, along the lines of the vaccine question, did you say that there were only 10 doses of the antiviral treatment in the state, or did I write that down wrong? Can go back and check.
Yeah, 25.
25.
Or 25 courses.
And so then the same question that was just asked in terms of availability, is that a concerningly low number? Do you think we'll need a lot more, and what's the plan?
Yeah, that's a good question. Right now, I mean, again, the presentation in general has been atypical in that it's been overall less severe. So in terms of treating people with severe disease, we think that is sort of more is less likely at this point in time. However, as we have more cases with potential risk factors for severe disease, like we talked about a little earlier with pediatric cases, or people with immune compromise, also people with other skin conditions that may make the presentation, the skin rash more severe, will want more. I believe at this point in time, there's probably enough for what we need at the current moment. And in addition, I believe at the level of the strategic national stockpile, there's less, it'll be easier to get more quantities as we need them. Whereas vaccine is sort of more dependent on the federal allocations based on cases and population, and then also based on production and the manufacturer of vaccine as well.
Thank you.
Thank you. And our final question comes from Fedor, again, with the Oregonian. Go ahead, Fedor.
Hi, I have several questions. So of the 6 cases, how many were in each of the 3 counties? And of those 6 cases, how many of the individuals had traveled? And how many of those 6 cases are connected to each other?
Yeah, great. So there's the one confirmed case in Multnomah County is the only case we know of that has had a travel history. There are 3 presumptive cases in Lane County, none of whom I am aware that have had a travel history, but one is a new case and we have not interviewed them. And then there are 2 new cases in Washington County, again, presumptive cases, and they have not been interviewed yet. So we don't know, just because they were identified literally overnight. So that information is pending.
Okay, and based on the information you have so far, what would be your best estimates of how common the infection is right now in Oregon? A, B, what do you see as the trajectory of the outbreak in Oregon?
Yeah, so I think we're definitely under-diagnosing Hmpxv cases at this point in time, and I think that's true across the U.S. I think as private laboratories come online and we streamline the process for testing at the public laboratory, I think we'll see more testing and more cases. In addition, at this point, what we've been seeing is and because there's underdiagnosis, there's likely transmission that we're not picking up. So I do feel that there's probably a good amount of community transmission occurring in Oregon that may be unrecognized for kind of the several factors, kind of related to this sort of more mild atypical presentation, the testing factors, and so the faster we can get vaccine out more broadly, which again has all these moving parts to it, I think the better or the more effectively we'll be able to curb that transmission. But without vaccination at this point in time, I do believe we'll continue to see more and more cases. And I think that'll occur over the US. And we've, since we have Europe as an example, where cases have, rapidly increased, I anticipate that may happen as well without an effective vaccine strategy.
Are we talking weeks or months?
So, one of the things we can think about is we have 3 cases in one day. So we're kind of rapidly increasing in the number of cases that we're seeing. So I would say weeks to months. Yeah.
Thank you.
Thanks.
Thank you for those thoughtful questions, all of you. And thank you to our experts today for joining, especially you, Dr. Menza. So if any reporters, any of our media partners have any additional questions regarding Hmpxv, feel free to email the inbox. You know the email. And I have provided the YouTube link in the chat for today. This news conference, this media availability will be carried. So if you need to go back and watch or record or check a soundbite, what have you, it's right there for you. Feel free to reach out with any additional questions. And thank you so much for your time, everyone, and to our wonderful experts, and have a lovely rest of your afternoon. Thank you for joining.
Thanks so much.
Recording stopped.